Shumanda, are you there?
Hello.
Shumanda, are you there?
Yes, I am there.
Okay, basically our radiologist is going to join bit late. Okay, so we'll shift your session to the first session. Is it okay?
Okay, fine, no problem.
Okay, then first the 2D, then we will go for the radiology, and after that the 3D session will go. Okay, thank you.
Okay, fine.
Very good evening to everyone. Today we have come to the third class of the head and neck module. I am Dr. Bitan Pramanik. I'll be your program coordinator for tonight. I welcome all my seniors and colleagues to this webinar today. And today we will be learning about the oropharyngeal and hypopharyngeal cancers, the conventional planning, the conformal planning, and the radiological anatomy related to it. So our class experts for tonight will be Professor Dr. Sushil Periwal, who needs no introduction, and our very own Professor Dr. Taposh Maji sir. So without further delay, Professor Dr. Sushil Periwal sir, I welcome you to West Bengal AROI chapter, this today's conference again, and I would ask you to please say a few words, please.
Good evening, everyone. Good evening, everyone. Thank you for AROI West Bengal for asking me to present to the group about conformal contouring and planning for head and neck cancer. I'm very pleased to be part of it, and I want to make this session interactive. So the more question you ask, the more value you will get out of it, because all the thing which I'm going to present is out there, is freely available and accessible to everyone through various sources. So to make it useful, I would request all the junior and the senior residents to make it interactive, to try to put question in the chat so we can make it useful and fruitful for all participants. Thank you.
Thank you so much, sir. Certainly, sir. So everyone having any doubts during the lectures by our faculty, you can post your doubts in the chat box, and I'll be happy enough to forward them to our faculty today. So next, I would like to call upon Professor Dr. Taposh Maji sir to say a few words, please.
Sir, please unmute yourself.
Okay. So I'm very happy to join you in this meeting. Welcome to Dr. Periwal. We will be discussing the planning, the three-dimensional, the modern planning, IMRT planning, and the 2D planning of oropharynx and hypopharynx. I hope that these discussions will be very fruitful and beneficial to the students, especially. So I just you can start the program.
Thank you so much, sir. So today we have a slight change in our program itinerary. So first we'll be starting with the conventional radiotherapy planning in oropharynx and hypopharynx malignancy. Dr. Shuman Mullik sir would be giving a lecture. Sir, you can start, please.
Thank you, Bitan. Let me share my screen. Is my screen visible?
No, sir, not yet.
Now?
No, sir.
Then probably I have to join from other device. Okay, just hold on, I'm
If
joining.
you can forward me the, so you can forward me the presentation. I can try from.
No, I'm joining from the other device.
Shumanda, just try once. Just try once.
Yes. So is it visible now?
Yeah.
Right?
Yes, it's visible. So you can start the slideshow.
Yeah. So
Yes.
thank you, ARY West Bengal chapter, for considering me in this discussion of oropharyngeal and hypopharyngeal carcinoma and two-dimensional radiotherapy simulation and planning that I am going to discuss today for oropharyngeal and hypopharyngeal CA. So as you know that most of our centers now, they do not have even that 2D simulator, and most of us has actually moved from 2D to 3D. So this presentation actually reminds my childhood in radiation oncology. So I started my training with 2D, then gradually moved to 3D, three-dimensional training, three-dimensional planning. So as I've been requested to discuss all these things, but today I will mainly emphasize on the simulation process, treatment portals, posterior neck treatment and dose prescription, and also I'll touch upon the overall treatment protocol and treatment volume as well. So I thought probably that radiology discussion will be over anyway, so we can discuss radiology before discussing the 3D planning in oropharynx and hypopharynx. So as all of us know that oropharynx is consist of bilateral tonsils, soft palate, base of tongue, vallicula, and anterosuperior surface or lingual surface of epiglottis, and hypopharynx consists of pyriform sinus, posterior pharyngeal wall, post-cricoid area. So usually these patients comes to us with complaint of, and mostly we see the squamous carcinoma. And once we see the patient, it's most important for us to do a proper clinical examination, but because probably the clinical image is the best image among all the images that we have. Even in today's era, having if you have everything in your hand, be it CT, MRI, PET, but still there is a utmost need of good clinical examination, and nothing can replace a good clinical examination. So we have to look at the nutritional status, performance status. We have to do careful local examination of primary and lymph nodes. Palpation, especially for oropharyngeal tumor, is important to understand the extent of disease, especially base of tongue disease. And it is important to do an endoscopic examination to assess the valvular extension or extension to pharyngeal wall or larynx. Because even if you don't have the endoscope there, so you should consider for indirect laryngoscopy to assess the mucosal extent, because mucosal extent you may miss with your radiological finding. And these are the workup details that we need to do. That one, we should go for examination under anesthesia if possible, and do direct laryngoscopy to map out the disease extent in details. And we should map in such a way that anyone can actually visualize the disease after the clinical examination. And then there is need to confirm the histopathology, do the basic blood parameters, and look at the fitness of the patient or performance status for concurrent chemotherapy if at all needed. And definitely there is a significant role of imaging. So most commonly we do the contrast enhanced CT scan or MRI. In some cases, like for base of tongue tumor, to understand the extent or infiltration towards the anterior tongue, it is better to have an MRI done if you have that in your institution. And basic chest X-ray and CT thorax is needed to rule out any pulmonary metastasis or any second primary as well. PET CT is not recommended for all patients, but in those patients where they come with significant nodal burden, for them there is a role of PET CT to rule out any metastatic disease at the beginning. So once you do the examination, so then it is the time for the staging of the patient. So I'm not going in details about the staging of oropharyngeal carcinoma, but the important aspect after HSCC 8 is, so they have divided in HPV negative and HPV positive oropharyngeal CA. For HPV negative, T1 is up to 2 centimeter, T2 is 2 to 4, T3 is more than 4, T4 is divided in 4A and 4B, that we all know. For HPV positive tumor, so there is no 4B as such. So even if it is very advanced T4, so it has a similar outcome like T4 in HPV negative oropharyngeal CA. For nodal staging, we all know for HPV negative, which is true for all head and neck sites apart from the nasopharynx, that N1 is less than 3 up to 3 centimeter, and ipsilateral lymph node. N2A is between 3 to 6 centimeter. N2B is multiple is ipsilateral but none more than 6. N2C is when it is bilateral. And there is, we divide 3 in 3A and 3B. 3A if it is more than 6, 3B when there is extra nodal extension is there. When we look at the HPV positive nodal staging, it's a pretty simple. If it is N1, that is only ipsilateral nodes less than, not larger than 6 centimeter. N2 is bilateral, none larger than 6 centimeter. And if it is more than 6 centimeter, then it is N3 disease. And hypopharynx is similar to 2 to 4, more than 4, and T4 when it is locally advanced, like when it is involving thyroid or required cartilage, thyroid bone, and T4B when it actually encases carotid artery or involving prevertebral fascia, we consider as a T4B disease. Now, apart from the staging of primary and considering because staging is important, and along with that, the important aspect is knowing the natural history of the disease of oropharynx and hypopharynx. If you look at the oropharyngeal tumor, the most tumor they come with the level 2 or level 3 nodal metastasis. So if it is clinically node negative, it is important to treat at least level 2, level 3, and most of the time we also include level 4 for oropharyngeal tumor, for some obvious reason that we know that the oropharyngeal tumors metastasize to these levels. And if it is a pathological or in plus disease, so then there is a higher chance of positivity of level 2, level 3, level 4, as well as sometimes it is level 5 and sometimes level 1b. And one important nodal station is there, that is retropharyngeal node, especially when lateral pharyngeal wall is involved, when posterior pharyngeal wall is involved. It is important to include retropharyngeal node in your radiotherapy portal. So most of the time we treat oropharyngeal tumor or hypopharyngeal tumor bilaterally, except in one situation, in early tonsillar lesion. So there contralateral nodal involvement, the chance of contralateral nodal involvement is less, and there we can consider of ipsilateral nodal treatment only. So these are the CTV. So as I am discussing about 2D planning, so I am not going into details about the CTV nodes of oropharynx or hypopharynx, but it is important to treat 2, 3, 4, and if required, retropharyngeal tumor. For hypopharynx, so for node positive disease, the lower level 4 involvement is more, as well as level 5. And these are the level and borders. I am not going in details about the levels and borders of neck nodal anatomy, so probably that will be discussed in radiological anatomy and later on in the conformal section. So most common histology, as I mentioned, we see squamous cell carcinoma. Other types are also we come across, like basaloid, spindle cell, sometimes lymphoma, sarcoma, etc. As I mentioned, examination is important and workup is important. And once we done our detailed examination and workup, it's important to counsel your patient about your treatment plan, the intended duration of the treatment, what are the options available, and expected side effects and benefits of the treatment. It is important to assess the nutrition of the patient, because if you consider for chemoradiotherapy, it is important to improve nutritional status or at least maintain nutritional status. And it is important to start swallowing exercise from the beginning. You should encourage to maintain oral hygiene. You always counsel about the skin care, and it is important to do a pre-radiotherapy dental prophylaxis to avoid any kind of radionecrosis or any kind of dental problem in future. So what are the treatment options we have? In short, for early disease, for T1, T2 with node negative disease, we consider for radical radiotherapy alone. For node positive disease or T3, T4 disease, it's a mandatory to add concomitant chemotherapy along with radiotherapy if patient is fit for chemotherapy. Surgery is the modality, has a limited role in oropharyngeal carcinomas, apart from very early small primary lesion, where transoral robotic surgery or ultrasound surgery is feasible. And I'm not going to discuss about the transoral surgeries today or adjuvant radiotherapy in oropharynx today. So first, once you decide that patient will undergo radiotherapy, after counseling, after taking a proper consent, it is important to do a proper patient positioning and immobilization. So during positioning, it is always important to counsel your patients again regarding the procedure. And after the consent, patient is usually kept in supine position with hands lateral position. It is important to give rubber traction, especially in two-dimensional radiotherapy for rubber shoulder traction, to ensure that shoulder should not come into your radiotherapy portal. And it also acts as a immobilizing device of the shoulders. And for neck rest, we need to identify the proper neck rest to make our spine, cervical spine straight, or make it a neutral neck extension. And then we make the thermoplastic mold. So while making the thermoplastic mold, the patient position should be comfortable. It should be reproducible every day. And while putting the base plate, you look at the whether base plate is properly placed and it touches the indexer or on the table. Patient neck should be in the neutral position. And it is important, if there is any large lymph node there, you mark the palpable lymph node with the lead wire, because this is not important for 3D planning, but it is important for the 2D planning when you are using X-rays. And it is also important for 2D plannings. If a transoral, you see the extension of the disease in the tongue, you can place a marker there to understand the anterior extent of the disease. And then make the mold, and it should made with a good impression of the bony landmarks, and laser should be properly aligned, and you can actually put a mark for the laser alignment for easy positioning every day. And this is the shoulder traction by which you can bring down the shoulder. And this is radiotherapy simulator. This was there in TMH when I was resident there, and this is a photograph taken at that point of time of a oropharyngeal simulation. So what are our targets in 2D radiotherapy? So one is the primary with adequate margin. What we mean by adequate margin, it depends on the primary. So mainly it is about 1.5 to 2 centimeter from the primary. We should have enough margin. We should include the regional lymph nodes. We should include the involved nodes, and we should include the nodes which are having a higher chance of getting involved in future. So based on the natural history of the disease, we should select the nodal levels to be irradiated. And these are the critical structures we should keep in our mind even in 2D radiotherapy, that is spinal cord, brainstem, eye and optic nerves and optic chiasm area. Apart from that, oral mucosa, ear, larynx, skin, cartilage, parotid, most of the time we cannot save it, and the temporomandibular joint. So let us see about the radiotherapy portals. So this is a typical radiotherapy portal for a oropharyngeal CH. So this patient has had a base of tongue tumor. So that patient needs radiotherapy to the primary as well as the neck node. The neck node included were 2, 3 and 4, and usually I'll discuss the borders later here. So this is the case of carcinoma base of tongue. This is one of our patients. So we have created a DRR image, and over that we have placed the portals. So T3, N3B and M0, he had a large neck node, and it was HPV negative and planned for CTRT. So upper border should, as it is a heavily nodal positive disease, that should be up to the base of the skull. Posterior border, here we have taken up to the spinous process of the vertebra. Anteriorly, we have taken 1.5 centimeter anterior to the primary, and lower entire neck was included. So this patient can be treated by bilateral portal or 3-field technique that I'll discuss next. So So this is the portal, and it is important. You can see that with this kind of portal, there is the chance of irradiating the lower part of the brain, which is cerebellum, and the significant amount of oral mucosa. So that we can actually block with the placement of the blocks like this. And usually we treat with the bilateral parallel opposed portal, and we go up to 45 to 46 gray in conventional fractionation. So and for the spinal cord tolerance, we cannot go beyond 45-46 gray with this kind of bilateral parallel opposed portal. And for that, and this is a different case, this is a hypopharyngeal case. In hypopharyngeal case, there is no need for anterior extension of that anterior field, so you can push the anterior field posteriorly to include your hypopharyngeal tumor, but cranial and lower extension will be the same. And this is after giving 45 to 46 gray. We need to reduce the posterior border from the spinal cord to anteriorly, and usually we keep posterior border at the mid vertebral body or at the junction of anterior 1/3 and posterior 2/3. And you should continue the blocking of oral mucosa like this if you do not have the MLC. So, but the problem with our patient was that patient had a large lymph node there. So once you reduce your posterior field, or once you shrink your posterior border, so you cannot treat this posterior part of the lymph nodal region with the photons, because the photons will give significant dose to the spinal cord. For that, it is important to add a posterior electron boost to give adequate dose to that nodal side. And usually posterior electron boost is given in a lateral position, and because you cannot keep your gantry at 90 degree or 270 degree with the electron cones. That's why we have to rotate the patient and treat posterior electron boost like this. And for that, this as I mentioned, the marking of the lymph nodal region or lymph nodal border is important at the time of simulation, because uh, you have to have the image of the wear while planning of the posterior electron boost, and to plan and to reduce the posterior border of your phase 2 bilateral portal. So sometimes we consider of phase 3 treatment when there is not much or nodal involvement. We can reduce the lower border upwards to reduce the dose to the level 4, and to reduce the low dose to the larynx in case of oropharyngeal tumor. And so off cord is done after 46, and this phase 3 is done usually after 60 gray or so. And once it is done, it is important to give the prescription. So how we prescribe? Usually we measure the separation at the upper border, at the middle, and at the lower aspect, and we take the average. We take the average of these three area, and on the basis of average depth, we prescribe the dose. But there is a problem in prescription of a dose like that, because we know that that upper part, the distance or depth is more, lower part though depth is less. So we always will see this kind of cold area upper part and hot area at the anterior part, because anterior neck the depth is less compared to your prescription depth. So this is the upper part transection, and if you look at the anterior part at the laryngeal area or anterior neck, you will see this kind of hot area at the anterior neck. So how can we avoid this kind of heterogeneity in the dose distribution due to heterogeneity of the neck anatomy? So we understand that there is a deficit of tissue in the neck. So that's why to overcome this heterogeneity, we can consider of placing tissue compensator. So how the tissue compensator is made? So usually two grids are placed adjacent to the patient, and usually distance are measured through the grid, and usually a 1 centimeter by 1 centimeter blocks are made like this. These are tissue equivalent blocks made of the alloy, and these blocks are made to create a compensation of the tissue deficit. So this is known as the tissue compensator. So this tissue compensator is placed at the time of treatment at the block tray in cobalt, in the treatment with the cobalt machine. And when you add tissue compensator, you will see there is no hot region at the anterior aspect, and there is more uniform dose distribution across the volume. So it is important to use this kind of tissue compensator when there is a significant, you are considering a significant heterogeneity in your dose, in your treatment volume. But there is still a problem when we look at the lower neck. Due to presence of shoulder, you will see there is limited dose in the posterior aspect of the lower neck. And for this patient, so that patient had a large node. So with the bilateral portal, actually you cannot cover the lower neck beyond the cricoid. So it is difficult in most of the time. So how can we come across this kind of interest? So for that, we need to add another lower neck, anterior neck portal. So here we can treat the same patient with the 3 beam, 2 bilaterals and 1 lower anterior neck portal. So, but there are some problem with the bilateral and lower neck portal, because with the lower neck portal, there is a divergence which can go into, the divergence can go into the bilateral portals. And as I mentioned, in the bilateral portals, with the divergence beam, that can actually enter, the high dose region can enter the lower neck portal. So how can we actually, so with this kind of overlap of lower neck with the bilateral, it can cause this kind of dose distribution. So there is a chance that your high dose region will come to the spinal cord region. So be careful while choosing this kind of 3 field arrangement. So it is possible, but you have to be very careful. So how can we plan for 3 field technique? So either we can consider for bi-isocentric. Bi-isocentric means, so 2 bilateral portal with the isocenter within that portal, and the third is the anterior portal with the isocenter in the third portal. And as I mentioned before, there is a higher chance of hot spot over the spinal cord and larynx. It is important to put a laryngeal block. Actually, this laryngeal block is made to block spinal cord dose, so that we can avoid this kind of hot spot over spinal cord and midline structures. There is another way of doing this, that is the monoisocentric way, where you can place your center at the junction. So if you place the center at the junction, there will be no divergence at the center, so there will be no overlap of your beam. And like the same, the lower neck also treated with the blocking the upper part. So either with the half beam block or monoisocentric technique, you can avoid this kind of divergence. So three field techniques can be done either bi-isocentric technique or mono-isocentric technique by half beam block. So, but in our patient, that oropharyngeal case, we have to be very careful. See, for this patient, that patient had a large lymph node involving level 2, 3, and 4 like this. So usually we always try to avoid any kind of junction over any gross disease, because to avoid any kind of low dose region over the gross disease. So whenever you are considering this anterior portal, you have to be very careful. If there is a disease, gross disease, it's better to avoid any kind of cold spot over there. You may allow some form of hot spot at this junction. And as I mentioned, for T1, T2 tonsil, instead of treating bilateral portal, if it is well lateralized tonsil, you can consider for unilateral or unilateral wedge pair portal to give adequate dose to the primary as well as the neck nodal region. You may consider direct lateral portal, but direct lateral portal is not a preferred approach because of heterogeneity of dose distribution. So once you are done with your simulation, it's a time for calculation. So treatment time for cobalt is calculated, that is the dose by dose rate. Dose rate is basically output into the several factors are there, and output is in cobalt is described as a centigrade per minute, or in linear accelerator it is centigrade per mu. And once you once you are done with your portals, you check the equivalent square, that is 4 into area by perimeter, and from the in case of cobalt, you have the chart of equivalent square along with the PDD chart. From there you can get the PDD, and with the PDD you can actually calculate the output and the treatment time. So this is the treatment delivery method with the cobalt and linear accelerator. Usually the total dose is given around 66 to 70 gray, 33 to 35 fraction in conventional fractionation, and two involved nodes again 66 to 70 gray. Phase 1, as I mentioned, it's we deliver around 46 gray, then got to phase 2 and phase 3 after 60 gray. For clinical planning, in those centers who don't even have the 2D simulator or the CT scan, they can consider for anatomical landmarks like you have to look at the clinical finding. So you can consider anterior border of masseter as the anterior border when it is a hypopharyngeal tumor, and posterior oropharyngeal tumor. Take up to the mastoid process, which will include the entire level 2. Treat up to head of clavicles in the inferior border, and usually we used to take tragus as off cord, and you can take cricoid cartilage for phase 3 reduction. So for take home message, that two-dimensional planning for oropharyngeal and hypopharyngeal tumors are feasible, and it is well time tested. It does not worsen survival compared to conformal technique if done properly in selected cases. So it is absolutely feasible, and but it definitely costs more in terms of long-term toxicity. So when you talk about salivary function, swallowing, quality of life, definitely there is a drawback of 2D planning system. That's why we will discuss 3D as well. So, but it is absolutely feasible, but it is important to understand the intricate of 2D planning as well, to have a better kind of dose distribution, to have a better outcome with less toxicity. So I must acknowledge my alma mater, Medical College Kolkata, because I learned 2D technique from Medical College, and then I refined my 2D technique as well, 3D as well as 3D in Tata Memorial Hospital, and now I am working in Narayana Super Specialty Hospital. So I thank you all, and I also my sincere thanks to all my teachers, from whom actually I learned my this 2D and 3D radiotherapy techniques. And thank you very much for giving me this opportunity. And now it's time for question probably. Thank you.
Thank you so much, sir, for this illustrious lecture. So we have a few questions. First question is by Dr. Abhay. So he asks, what should be the lower border for the lateral fields in the phase 3 in case of carcinoma oropharynx?
For lower border, that depends on your nodal involvement. So if it's a node negative tumor, so you may consider of not treating contralateral level 4. You can reduce the lower border up to the lower border of the cricoid cartilage.
Yes. So our second question is by anonymous attendee. So his question is, what is the clinical planning difference if retropharyngeal lymph node is positive or negative in taking the upper border in 2D planning?
Yes. As I mentioned, if you want to treat retropharyngeal, so you have to take from the base of the skull, and posterior border phase 1 that includes retropharyngeal itself. And you have to be very careful about while taking the phase 2 when you are actually making it anterior. So in that case, you should be very careful about, you look at, if possible, if patient is having a CT scan, basic CT scan at the time of evaluation, you look at the CT scan, you look at the location of the retropharyngeal node, and based on that you decide on your posterior border of at phase 2. So if not possible, then please don't consider for treating for gross retropharyngeal node, don't treat it as a 2D technique, because in phase 2 you may miss retropharyngeal lymph node if it is going posteriorly or if it going parapharynx, because sometimes you cannot cover that with electron boost adequately. So you have to be very careful. And one thing also important, if there are bilateral large node, so you have to be very careful while planning for bilateral electron boost, because you should usually we take energy as 1/4 for 90% coverage. So there you have to be a bit conservative, because you should not try to cover it with the 90%, because in that case your spinal cord will get some dose from both the side. From one side that is fine, so in that case you have to choose a lesser energy like 9 MeV like that, to avoid any hotspot over the spinal cord.
Thank you, sir. I think that's the two questions we had for this session. Thank you so much, sir, for your lecture. So we would move on to the next lecture for tonight, and that would be radiological anatomy for radiation oncologists in oropharyngeal and hypopharyngeal cancers. Our speakers will be Dr. Shonok Paul, sir, consultant in Disan Hospital, radiologist, and Dr. Kaustuv Majumdar, sir, consultant radiation oncologist in Chittaranjan National Cancer Institute. Sir, I would like you to take the lecture forward. Thank you.
Thank you so much, and I'm extremely sorry for rescheduling of today's lectures. I got a bit delayed. Please pardon me, everybody. And thank you again, AROI team, for having me on the platform. Shall we start off with the session? Dr. Kaustuv, are you there?
Yeah, so we are going to start this session. So just a summary for today's session. Today we are going to discuss the oropharynx and hypopharynx and their, sub division of it. And along with it, for the neck node, contouring, there are some tricky structures. We are not going to discuss the details of it, but we are going to take some, the proper tricky structure, what is present in the neck node contouring from Dr. Shaunak, our radiologist. And on the next day, we will give you the, the space and everything and all the border. So, so we're going to start first with the oropharynx. Dr. Shaunak, over to you. Hello.
Hello, am I audible? I'm sorry.
You're audible. Over to you.
Yeah,
Please
yeah,
start.
thank you. So we will stick to our prior plan of action, as in you will put up the questions and we will start with the anatomy. Shall we go with that, sir? Dr. Kostab? Okay, I think we have lost connect with him. So we will start with whatever we have at this point of time. First, let's define the oral pharyngeal cavity and how do we actually demarcate which part of the cavity is what. This is not a straightforward anatomical case, but this is a pathological case because of not having a normal anatomical case at this point of time. So first thing, we draw a few lines on the sagittal and along the inferior margins of the vertebrae. So this is the line along the inferior margin of the C1 vertebra. This is the anterior arch of the C1. This is the posterior arch of the C1. And this is another line along the inferior margin of the C3 vertebra. And this is another line along the inferior margin of the C6 vertebra. Up to the C6 vertebra is usually the span or distribution of the pharynx. Anything that is above the level of the C1 is the nasopharynx. From the inferior border of the C1 to the inferior border of the C3 is the oropharynx. And from the inferior border of the C3 to the inferior border of the C6 is the hypopharynx. This is a relatively simplistic way of dividing the pharynx, and the anatomy or the acquisition technique or however the patient is positioned, that might have a bit of variation in between the zones that we are talking. So first thing that I had been asked by Dr. Kostab is for the oropharynx, and we will go into that first. So as we finish off with the arch of C1 and come to the base of the C2 vertebra here, this is the level of the oropharynx. Okay. And what do we have here on sagittal? It is better appreciated. Dr. Kostab, are you still online with us?
Yeah, I'm here.
Okay. Okay. Yeah. Okay, sure. So first thing is what we had discussed earlier, the oropharyngeal portion of the tongue, the posterior third of the tongue, and this level of the vallecula. These are all included in the oropharynx, and as well as some part of the posterior aspect of the free margin of the epiglottis. Okay, and this is the posterior margin of the oropharynx here. And what I think Dr. Kostab had asked me to show the constrictors of the pharynx, and that will be a pertinent thing at this point of time. So starting from above, sorry. So we have a sling of muscle here. This is the superior constrictor, or again, going back to the sagittal. So whatever muscle is in this area up to the C1 and up mid body of the C2, this is the level of the superior constrictor. This is the posterior margin of the pharynx. Okay, this is the posterior margin of the pharynx, and then is the level of the middle constrictors. This is the arch of muscle that goes and inserts into the hyoid bone. This is the level of the middle constrictors, pardon me. And as we go below at the level of the inferior margin of the hyoid bone and at the same level of the inferior margin of the mandible, this is the level of the inferior constrictors. So what was your next question, Dr. Costa? Vallecula?
Can I ask you one thing? What
Yes,
will be our inferior border of the inferior constrictor where we should complete our
okay.
the contouring?
So when we have this is the cricopharynx. Okay, I'll come from below. This
Yeah.
rounded structure behind the trachea is the cervical esophagus. And when it flattens up here, the same tubular structure is flattened out. This is the cricopharynx, and the muscle that is just above the level of the cricopharynx, this is the level of the inferior constrictors. So by the time you see the cricopharynx, your constrictors are over. So that should be probably your demarcation between the two.
Okay, thank you. Next we'll start with, I think, the tonsillar fossa. So could you please show us the, anterior and posterior tonsillar pillar and the muscles accordingly there?
Okay, so we trace from the retromolar trigone. This is the area of the body of the mandible forms the ramus, and this fat plane here is the retromolar trigone. When we can trace some air locules here because of puff cheek position, and this soft tissue that extends up to the paramedian area is the anterior tonsillar pillar, and the one that is posteriorly going up to the constrictor, this is the posterior tonsillar pillar, and we have some amount of fat in the paraglottic fat. This area in between is the tonsillar fossa. Next, Dr. Costa.
Okay. Am
I clear on this?
Yeah, it's fine. So in the first class, we'd forget to describe the pterygomandibular brachy. So could you please show the, the exact,
Sure. So this is a pterygoid muscle, lateral pterygoid muscle. Inferiorly, this is a medial pterygoid muscle. So as we go behind the lateral pterygoid muscle, you can see some frill-like structure here.
Yeah.
This is between the mandible and the pterygoid process, as well as the medial pterygoid hamulus. So this entire frill-like structure where you have some vessels here, this is the region of the pterygomandibular raphe on an transverse image. And as we go cranially, we can see this ends up at the level of the foramen ovale. So I'm going again down, foramen ovale down, and we have this frill-like structure here. So this is the region of the pterygomandibular raphe. Okay.
Thank you. And next we move to base of the tongue then. So base of the tongue, is anteriorly by circumvalent fibula. Already Dr. Shonak has told in the first class. And next is inferiorly by the vallicula and epiglottis. Now it's up to you. So should our vallicula and the part of the epiglottis along with paraglottic and pre-epiglottic part.
Okay. So we have this patient particularly has a tumor in the level of the epiglottis extending into the vallicula. We will try to show whatever anatomy is seen through this. This is a median glossoepiglottic fold, and this muscle here, or this mucus double lining here, is the lateral pharyngoepiglottic fold. So the air structure in between these two is a vallicula, better appreciated on a sagittal image. So this is the posterior margin of the tongue. This is the anterior margin of the epiglottis, and the air space in between is the vallicula. So when you have some structure at the posterior margin of the tongue or the anterior margin of the vallecula, please do not call it a malignancy per se. To have a malignancy in this zone by radiology, you will have to have a defined soft tissue along the anterior margin of the epiglottis, the free margin of the epiglottis, or the floor of this vallecula. Okay, anything on the anterior margin of the vallecula is usually a lingual tonsil which mimics a mass. So whenever you have a lingual tonsil, please don't consider it as a mass, and see whether it extends into the floor or the posterior wall of the vallecula. If there is no extension, it is just a lingual tonsil. Don't consider it for any therapeutic interventions. Okay, sir. Next question,
is the
please.
paraglottic and pre-epiglottic phase, please, because I mean, if there is any invasion or disease is there, so we cannot see it properly.
Yes. I think this case will describe that better. So this fat plane on either side is the paraglottic fat. Okay, and when we go on a sagittal view, the fat plane inferior to the inferior margin of the vallecula, this triangular fat plane is the pre-epiglottic fat. Okay, so how do we define it? It is the hyoid to the epiglottic, hyoepiglottic ligament, and between the tip of the epiglottis, which inserts onto the thyroid cartilage. The fat plane in between these is this is the pre-epiglottic fat plane, and when we go for a coronal imaging, it is the paraglottic fat plane is still better appreciated. This on either side is the paraglottic fat plane. So the preglottic fat plane here and the paraglottic fat plane on either side are in communication. So whichever fat plane is involved, these are very highly lymphatic, and nodal metastasis is very common in these. So in this particular case, we have a mass in the epiglottis which extends into the preglottic fat. The preglottic fat is all shaggy, it is all stranded, and we have a lot of lymph nodes, necrotic lymph nodes on level 2 on either side. So this has a nodal metastatic disease along with the epiglottic tumor. Okay, next question, sir.
So, so I think we done with the oropharynx because you have already shown the soft palate and alveolar part in the first class. So I will move to the hypopharynx. So could you please show us the the hypopharynx boundary from in the both in the coronal and axial section from where to where we designated as a hypopharynx.
Okay.
And
what are the structures that involve that? Fine. So this is the inferior margin of the cricoid cartilage. Okay, I'm going down, you form the trachea. So we go from below the inferior margin of the cricoid cartilage, just posterior to this. Give me a second. Just posterior to this, the anterior portion of the cricopharynx is the postcricoid area. Okay. So this is the postcricoid area, and this is the posterior hypopharyngeal wall. The entire thing is, and there's another third component of the hypopharynx, which is the piediform fossa. You have a triangular air-like structure, air-filled structure on either side. This is the piediform fossa. And as we go higher, we have a structure which goes obliquely from the lateral aspect to posterior medially. This is the ariepiglottic fold. So the posterolateral aspect of the ariepiglottic fold is a part of the piediform fossa, and it is a part of the hypopharynx. Whereas the
arytenoid.
Yes, I'll come to that. The anteromedial is part of the larynx. Okay, and a triangular cartilage on right and partly calcified cartilage on the left. These are the arytenoids sitting on the cricoid cartilage. Okay. This is the cricoid going up. These are the arytenoids. Okay, sir.
Okay, fine.
So this is the anterior margin of the arytenoid, and from there is the vocal cord, true cord.
So first, in the piriform sinus, could you please show us the extent of piriform sinus, that is the superior, inferior extent? You have already shown the lateral and medial also.
I'll see if I can do that. Okay. So superiorly, it is the superior margin of the aryepiglottic fold, and inferiorly what we have is the apex of the piriform sinus. Okay, where the air vanishes and you have some fat attenuation, which is similar to that the paraglottic space, paraglottic fat. So if you have a piriform sinus tumor which involves the apex of the piriform sinus, it usually goes into the paraglottic fat here, and it being a pharyngeal tumor gets to go into the laryngeal spaces. Okay, sir.
Okay. So in continuation with it, could you please show us one structure, that is the thyrohyoid membrane here, because it is, not in the laryngeal part, but yes, it is. When there is a
that's
disease extent, then it will
extension of the tumor from the hypopharynx into the larynx. We will have to consider whether it is going extralaryngeal as well or not.
Exactly.
So this is the inferior margin of the hyoid bone. As we go inferiorly, we have this thyroid cartilage, which is partially calcified. And this line, which is anteriorly formed, lined by the strap muscles, infrahyoid strap muscles. And so this just hypodense line, this is the level of the thyrohyoid membrane. Okay,
fine. So anything, if you cannot see this line, then it might be a disease extension from the.
If there is a tumor in this paraglottic space that goes and infiltrates the strap muscles, infrahyoid strap muscles, then there is extralaryngeal extension of the tumor across this.
Okay. The last thing I want to ask you regarding the post-cricoid region, you have told that is already below the cricoid it is started, but what would be the extent? Could you please show us?
Post-cricoid region, the upper margin is the level of the upper level of the cricoid bone here, and then as long as the cricoid bone is there, we call it as a post-cricoid region. And this is better so appreciated. 1 second. So the cricoid cartilage is superolaterally small anteriorly and large posteriorly. Okay, this is a triangular shaped disposition on a sagittal view, and the soft tissue that is the posterior to the level of the posterior margin of the cricoid is the postcricoid region, and immediately abutting it is the posterior hypopharyngeal wall. Okay, sir.
Okay, fine. So as we have some time here, so could you complete the, could you show us in CT scan the thyroid gland and parts, whatever can be seen in the CT scan?
1 second. So on either side of the trachea is the thyroid gland, and this enhances avidly in post-contrast imaging, and even on plain imaging, it is usually hyperdense because of intrinsic iodine. And this is the right lobe of thyroid, left lobe of thyroid, joined in between by what we call the isthmus. Isthmus is usually less than 2 millimeter in anteroposterior thickness, and it is a bit difficult to appreciate it. But if you can trace the hyperdense structure from on either side anterior to the trachea, you can find the level of the isthmus.
Okay, let's see. Thank you. So we are going move to the, levels of lymph node levels, not the details of it, but we'll start some tricky structure as I already mentioned. We'll start with level 1A and 1B. So I think you could move upwards, I guess, Shonak. So could
Yes,
you
sir.
please show us the mylohyoid muscle again once?
Yeah, 1 second, sir. For mylohyoid, I would always advise you to go for a coronal image. Okay. So this is the hyoid bone. These are the mandibles, and whatever U-shaped muscle that connects the entire thing is the mylohyoid muscle. And then you trace it anteriorly and posteriorly. So when first you find the hyoid bone, whatever U-shaped structure is connecting all through and through is the mylohyoid muscle, and then you go anteriorly. This is the mylohyoid, and these are the anterior bellies of the digastric muscle. Any nodes that are between the mylohyoid and the anterior belly of the digastric on either side is the level 1A lymph node. Continuation to this is a level 1B lymph node. Yes, sir.
Again, please
Sorry.
in the axial section, please. Sorry.
Axial section. Yes, yes,
Yeah.
yes. Sorry. So this is the mandible, inferior margin. This is the hyoid. And so I will put it as a MPR so that it will be easy for you to. Are you able to see the screen?
Yeah, sure.
A 3-split screen?
Yeah, absolutely.
Is this okay? Okay, fine. So it will be easy for you to understand. This is the U-shaped structure. This is the U-shaped muscle that we talked about. And on axial, this is the level of the mylohyoid. So this is the mylohyoid. Any nodes in between this triangle.
So this is the anterior belly of digastric, I guess.
1 second, sir. This one is the anterior belly of digastric. And as we go higher up, this is the mylohyoid. At the medial, these are opposed on each other. So it will be difficult on axial for you to take it up, but the bigger, larger muscle is the anterior belly of the digastric. As you move a bit higher, this is the mylohyoid on the medial margin of this. Okay.
Okay, thank you. So next I move to the platysma muscle, upper and inferior and superior thing, and you have to identify. We have to identify.
Okay. Okay. So this small thin structure here on either side is the platysma muscle.
Okay. So superiorly, how where I up to which section I can see
up
it?
To the level of the angle of the mandible, you can see it properly. Okay, this is the angle of the mandible, and then you can see the platysma. And inferiorly, you can see it up to the level of the hyoid here. After that, it goes on a transverse plane, and this is the muscle, and it is spread out in the axial section, so it is difficult to make it out. Okay, this is your platysma here. Next.
So this is also the platysma, na?
Yeah. Yes, sir.
Exactly.
Yes, sir.
Okay,
this is
so
the platysma, and these are the lymph nodes on the level 1A station.
Okay, so
these smaller ones, sir.
This smaller one, no? Okay.
Yeah. Yes, sir.
So next we move to I think you have already shown us the mylohyoid muscle here. Could you please just give us these things?
This thin muscle here is the mylohyoid muscle.
Okay.
This thin on the either side, last muscle on either side.
Sorry.
This is the big fat muscle of the anterior belly of the digastric. Just when you finish this is the mylohyoid here.
And next
always try to
in the
sorry.
In the sagittal section. Okay, sorry. Next is the you have shown me the posterior belly of digastric. You have already shown us the anterior belly. This is the
posterior belly of digastric. Again, is another tricky thing. This is the anterior belly. It forms, it tapers down, and on CT, sorry. On CT, the muscle here in between is the posterior belly of the digastric.
In between which? I mean,
In between the submandibular gland here and the muscles of the tongue here.
Okay. So this is the, I
Okay.
mean, okay, so this is the
The
posterior.
anterior belly you can see separately because of the fat on either side. It tapers down and then again it goes posteriorly between the submandibular and this tongue muscles.
So we'll move to the
Here.
level 2 to level 4. So there is one tricky structure here in the medial boundary of the level 2, that is the scalenus muscle. So there are 3 scalenus muscle. Could you please show us? Scalenus.
I can only show you the scalenus anterior, which will be your defining structure for differentiating whether it's a level 4 node or a level 5 node. Okay. So at the level of the transverse process, the muscle here is the scalenus anterior. Okay. And this is the lateral margin of the sternomastoid. So when we draw a line from the lateral margin of the sternomastoid to the lateral margin of the scalenus anterior, any nodes that are, I'm on a higher plane, I'm sorry. Any nodes that are in between these, on medial to this line, is in this fat plane is this level 4, whereas the nodes on the, it was medial is level 4 and lateral is level 5 lymph nodes. Okay, this muscle here on just behind the carotid sheath is a scalenus anterior muscle of yours.
Could you please show us its superior and inferior extent?
Yes, the inferior extent is onto the first rib here, and as we trace it, this is a scalenus anterior here, and it finishes onto the transverse process of the cervical vertebrae. This muscle, I am just running it through again. This one, inserting on the first rib. Okay. And next, doctor, next question.
Next, we are moving to the level 4B lymph node. So there are some, I mean, vessels, vascular structure we want to know here. So here, please show us the, I mean, the brachiocephalic vein, the trunk on the right side, and the subclavian artery. I mean, in the both sides, because there is some anatomical difference between left and right here. So,
okay, okay. Both side, I will have to take. First thing, I will beg your pardon. This imaging data set does not include the entire brachiocephalic vein. Okay, so we have what is the IJ on either side. These are the big fat IJs. And as we trace the IJs down, there's a right subclavian vein, which is anterior and just in deep to the clavicle. And whatever forms from this into the mediastinum is the right brachiocephalic vein, okay, which is a short vein. And on the contralateral side, this is the IJ. You trace the IJ, and the vein that comes and joins is the subclavian. And this is the origin of the left brachiocephalic vein. These two fuse to form the SVC. I don't think the entire thing is
not
in this
here.
imaging data set.
Okay. Fine. And in the subclavian,
we can just see the IJs and the subclavians forming. Yes, please tell me.
Fine. So, okay, fine. So might be in the next class, if we have some thoracic things is there, then you might show all these things, I guess, isn't it?
We will take up some thoracic cases. Yes, definitely.
Okay.
Definitely.
Next,
yes,
we'll move to the transverse
that
cervical.
Will be all, or
no? Just one thing. We'll move to the transverse cervical vessels because it is very much important.
Sorry, I couldn't.
Transverse cervical vessels. Can you hear that? Hello.
Okay.
Transverse cervical.
Yeah.
So because
yes, I'm hearing.
Yeah. This is important because of the demarcation of the level 5 lymph
So,
nodes.
Doctor, I cannot hear you. I am
Hello?
sorry. I'm getting disconnected.
Hello, can you hear us? Hello.
Doctor, I cannot hear you. Yes, this is a lot better. Yes, I
Yeah,
can hear you. I can
yeah,
hear
okay,
you.
okay. So transverse cervical vessels,
Hello.
please.
Hello.
Hello.
Hello. Can you see the slide?
Yeah, we can see
Dr.
your
Kostov, is
slide.
the
Yes,
slide
we can see your
visualized?
slide. Yes, yes. Hello.
Level 5, right?
Level 5. I mean transverse cervical vessels.
Level 5, right?
Yeah.
Ye-
I cannot see your
Okay,
yeah. Are you
I'll
moving
just
your
go
slides?
to a particular slide.
Are you moving your slides? We cannot see it. I cannot see it.
Yes, yes. Okay, okay, 1 second. Now can you see?
Yeah.
Okay, so we define the level 5 as from the level of the skull base up to the clavicle, and anteriorly this is along the posterior borders of the 2, 3, and 4, and posteriorly is through the trapezius. So what we do radiologically is not based on the vessels, is based on the muscles. This is the sternomastoid muscle. The posterior margin of the sternomastoid, this is the trapezius muscle, to the anterior margin of the trapezius. This is the level of the level 5 lymph nodes that we take into consideration radiologically. So when we are doing this, so this is the posterior margin here. Again, oh, sorry, I have to reshare this screen. 1 second. I think the Radiant software is again visualized. So what we do is, this is the posterior margin of the sternomastoid muscle, and this is the anterior margin of the trapezius muscle. The entire thing, the entire fat plane in between is the level 5, starting from the level of the occiput or the occipital bone to inferiorly up to where we see the clavicle. Okay.
I think in our
Am I audible?
Yeah, you are audible.
Dr. Kostov, am I audible?
Yeah. Can you hear me? Hello. Anyone hear me? Monidipa?
Yes. I think it's a problem from that.
Yeah, I think Shonak, are you? Can you hear me?
Partially. Yes, please tell me.
Okay.
Yes.
So, okay, fine. Our concern is the transverse cervical vessels. Could you please show?
I can hear a few words from you, sir. It's not very audible. I'm sorry.
I think the his connection is lost here.
Yeah, this is the level of the transverse cervical vessels that you're asking for. This is the subclavian artery, and these are the transverse cervical vessels. I think there is a.
Okay, this is a cervical vessel. Okay, fine. Okay, we'll show you the next show everyone in the next class when the transverse cervical vessels appears.
That defines your boundary, I think, from your literature,
caudal
right?
boundary. There is a caudal boundary of our literature. So the last thing, please show us the levator scapulae muscle.
Caudal boundary according to literature.
Shonok, the last structure, please show us the levator scapulae muscle, and we will wrap up.
This muscle is the levator scapulae, this triangular muscle that goes just anterior to the trapezius. Okay.
Fine. Thank you. So I think
this is the scapula here. Okay,
we are done for today, I guess.
For the day. Thank you.
Yeah. So is there any question, Bitan?
Yes, thank you, sir, for that wonderful lecture, Shonok sir and Kosta sir.
Thank you
I
so
got
much.
logged out in between, so I've lost the question. So as far as I remember, Dr. Saili asked, what is the superior extent of larynx?
Okay, I guess there's this question to be dealt in the next class. Okay, those larynx is to be dealt in the
And
next class.
there was another question by Dr. Abhay, as far as I remember, that he asked about the boundaries of pyriform sinus.
Extent of the pyriform fossa, what are their boundaries? Could you
Okay.
please just show us?
Yes, I'll repeat
One
whatever
more
we
time, yeah.
discussed. Yeah, the triangular air structure here is a pyriform sinus. Anteromedially is the aryepiglottic fold. Inferiorly is the pyriform apex, which is formed when we find a fat plane just above that. The air locule is the pyriform apex, and superiorly the base of the pyriform sinus is at the level where the aryepiglottic fold ends. Posteriorly, this is the inferior constrictor muscle, and as we go posteriorly inferiorly, it is the posterior hypopharyngeal wall. And there is something called a thyroarytenoid gap, which I think we will deal with in the larynx. But since we are discussing, this is the arytenoid cartilage, this is the thyroid cartilage. There is a conduit of fat plane between the paraglottic fat and the hypopharynx. So any tumor in the pyriform apex can extend through this into the larynx, and a hypopharyngeal tumor, posterior hypopharyngeal wall tumor, also can extend through this conduit into the larynx. Okay, I think that will be all for the pyriform sinus anatomy. Shall I go through it again, or is it clear?
No, it is absolutely fine.
That answers the question. So
Yes.
thank you so much. So next I would move forward to our next lecture. We have Professor Dr. Sushil Periwal. He will be speaking on the overview of conformal planning in oropharynx and hypopharyngeal malignancy. So I would request Professor Dr. Sushil Periwal to start your session, please. Thank you.
So good evening, everyone. Since we are starting 10 minutes, I have to be done on time. So I'll try to make it as fast as possible just because of the time constraint. But before I get started, I want the trainees to get something out of it. So I'll ask some questions, and please put your answer in the question and answer session just for me to understand how much of it you have the understanding. So when you are defining CTV, the highest risk CTV for head and neck cancer, how much margin do you give from GTV to CTV? So please answer in the chat so I understand where we stand, and so we can go through these questions as we go through it. So how much margin from GTV to CTV for the 70 gray volume? That's first question. Just be interactive and answer in the question and answer session. Second is, how much margin would you give from the CTV to PTV in your head and neck cancer? What margin would you give from CTV to PTV? And what imaging would you do at what frequency? Third is, what would you use as your dose constraint for constrictor muscle, for your salivary gland, including submandibular gland and parotid gland?
So we have a few answers. First, GTV to CTV margin, they have answered 5 mm, and CTV to PTV, they have answered 3 to 5 mm.
Good. And what about the constraints? Anybody is into the constraints? And last but not the least, what is the spinal cord tolerance? Like, what is the spinal cord tolerance? What would you say the spinal cord tolerance? Good. So, like what I will talk about, I mean, I didn't know like what was the other talks are all about. So there is some duplication what I'm going to talk about is, but I will talk about.
So they have answered Tmax less than 45 traces.
Okay. So we'll talk about it as we go through it. And so, when we do conformal radiation therapy, it is very important to be able to define the target correctly, which includes GTV, CTV, and PTV. And it is also important to be able to know the dose constraints for the organ risk. So you need to be able to define organ risk also. So unlike 2D planning, the 3D planning is conformal, and if you're not defining your target appropriately, you can miss the target. So the most important concept is the GTV, which is based on diagnostic information from clinical exam, endoscopy, laryngoscopy, and imaging. Now, when you use PET-CT, it is very important to understand that the windowing of PET-CT is very important. You could make a GTV look bigger or larger depending on how you window your PET-CT. And people have done studies looking at PET-CT windowing at the level of liver, 40% of maximum, 50% of maximum, defining by SU maximum or threshold. Out of which the worst way to define GTV is a threshold, SUV. If you use some arbitrary threshold of SU of 3 and above, the GTV tend to be very large. When they looked at pathological study looking at size of the GTV on the surgical specimen, it usually corresponds to about 40% of a maximal SU as your GTV. So it's important when you are defining your GTV on the PET scan, you window it appropriately. In post-operative cases, it's important to read the operative note and post-operative pathology because that's the hardest to define. And if you're using different diagnostic imaging, you need to make sure your registration is correct. If the registration is not correct, then your GTV and CTV can look whatever you want to look. So all these are important things for no matter what head and neck cancer you treat. The examination finding, the imaging finding, including PET scan and windowing, looking at post-operative and pathology appropriately, and when you're using imaging, making sure the registration is correct. Now, the definition of GTV and CTV varies in terms of in head and neck cancer, but the Danish group came up with a contouring guideline which was adopted by North American, Asian, and Australian Association. So GTV is, as we all know, is what we see based on clinical exam and imaging. But the CTV is where it varies things. So they define two CTVs, CTV1 and CTV2. Now CTV1 is the highest the risk volume, where they define GTV plus 5 millimeter as the highest risk volume, adhering out for bone and the natural barrier. But CTV2 is where the most variation lies. So like some people treat CTV2 as entire organ. Like if you have laryngeal cancer, they'll treat the entire larynx to CTV2. If you have basal tongue, they'll treat the entire basal tongue to CTV2. If you have tonsil, you include the entire tonsil as CTV2. What the Danish group tried to do was to make it consistent, and based on the consensus guideline, they said we don't need to include the entire organ. So the CTV could be 10 millimeter margin, accounting for the natural barrier. Now, not necessarily people follow that. Some people still treat the entire organ in CTV2, others do CTV2 as the GTV plus 10 to 12 millimeter margin. So you need to understand it's not sacrosanct, but there are ways people define it differently. If you do 10 millimeter or 12 millimeter margin following the anatomical landmarks, then you have less volume to treat and you may have less morbidity. But that being said, if you're not sure about it, some people still treat the entire organ in their CTV2 volume. Thirdly, like some people do 3 volume, so CTV1, CTV2, CTV3. But people have scaled down to 2 volume, one to 50 gray, other to 70 gray. But some people still use intermediate risk volume, although we do not know whether that makes difference or not. And the CTV3 is basically the CTV2 with prophylactic lymph nodes, which you take to so-called 50 gray volume. So it's important that when you're defining your GTV, CTV, and 1 and 2 and 3, you are consistent in how you do things in your practice. As I said, it's not necessarily everybody does CTV2 as 10 millimeters. Some people include the entire organ. And for the CTV3, the prophylactic node, you go at least above and below your involvement. And if there is extracapsular extension, especially around the muscle, you include the adjoining sternocleidomastoid in your CTV volume. Now, the PTO margin, which the question I asked varies, but if you're using 3D imaging like CBCT daily, then there is data to suggest that we can reduce the margin to 3 millimeter. And by doing it, the local regional recurrence looks very similar to what it would be with 5 millimeter, but the risk of mucositis, swallowing difficulty, and xerostomia goes down. So before you embark upon reducing the margin in your practice, make sure your setup is reproducible. You have documented that your setup is reproducible, and you're doing some kind of 3D imaging, which is cone beam CT, on a daily basis. Otherwise, reducing the margin can cause geographical miss. So in our own practice, we do daily cone beam CT, give 3 millimeter margin with the idea that it can help reduce the mucositis, swallowing dysfunction, and xerostomia. As I said, when you do the post-operative setting, then the volumes tend to be a bit more generous. And if you're not sure about it, you include a larger volume in your CTVs. Like this is an indication where it's R0 resection, so you have well-defined area to treat. But if you have R1 or R2 resection, then you again need to follow the same principle of defining your GTV, CTV, and PTVs. Now, this was part of the discussion in terms of lymph node level. Now, in the new nomenclature, we follow a nomenclature which is a lot more standardized now. So when you're defining a node, you can follow those nomenclature in your practice. And as defined, like by the previous speaker, the different level of the node. But I will show you some landmarks which as radiation oncologists need to understand. So as a radiation oncologist, you need to know these anatomical landmarks. So one is anterior belly of digastric. You can see the anterior belly of digastric. Second is submandibular gland, because they will define your level as we go through the talk. Third is the hyoid bone. Fourth is the cricoid cartilage. Fifth is the carotid vessel. Sixth is sternocleidomastoid, and seventh is the trapezius. So these landmarks will help you define the nodal volume. I mean, there are some complicated way of doing it, but as long as you understand these landmarks, you can easily define level 1 to 5 lymph nodes in your practice. Just make sure you identify those anatomy in your practice. So say, for example, this is level 1A, which is in between the anterior belly of digastric. Now, level 1B is lateral to the digastric, but the posterior edge is around this submandibular gland. So this is 1B. This is 1A. Now, level 2 starts from C1 level, and it has 2A and 2B because anterior posterior, although in the new definition it's only 2. So this is anterior 2 and this is posterior 2. And you can see this sternocleidomastoid. Level 3 is from higher to cricoid, and the level 4 is below the cricoid. What is important is in the new definition, level 5 is again 5A, 5B, and 5C. So 5A is posterior triangle node at the level of level 2. 5B is posterior triangle node at the level 3. And 5C is posterior triangle node at the level of level 4. And level 6 will go through and talk about it. So identifying the structures will help you define the nodes. And in general, for oropharyngeal cancer, 2, 3, 4 node is at risk for N0 disease. But if there is N positive disease, then sometimes you cover level 1B and level 5 nodes. So again, this is submental node. You can see there is a submental node right there. You can use this anatomical landmark, but important things to realize is it's a space between the anterior belly of digastric. Again, level, as I mentioned, level 1B node is lateral to the 1A, extending up to the posterior edge of the submandibular gland. And this is a level 2 node. Now, level 2 node extends from C1 to the caudal edge of the hyoid. And again, like whether we treat up to the skull base or not depends on the situation. So in patients where if it's N0 disease, we do not need to treat up to the skull base because higher up nodes are not at risk. In the surgical series for N0 disease, where the nodal involvement at the skull base level was close to 0. So in N0 disease, you can skip the upper level 2 nodes and treat 2, 3, 4 nodes. By doing it, you do not affect the risk of recurrence, but what you do is you decrease the risk of xerostomia by exposing less spirometry. This is another example of the 2B posterior to the spinal accessory, and this is a medial jugular we talked about from hyoid to cricoid, and these are lateral to the carotid, and again up to the posterior edge of the sternocleidomastoid. And we talked about level 5A from skull base to cricoid and 5B from cricoid to clavicle. Or somebody was mentioning about the transverse cervical vessel. But usually it's without contrast, sometimes it's hard to identify the transverse cervical vessel. So you can go up to the clavicle for you to define the level 5 node. You can see this is what we are talking about from trapezius to the posterior sternocleidomastoid. You can see the level 5B node. And 5C is at the level of level 4 node, which is basically from the lower edge of the cricoid all the way up to the transverse cervical vessel. So basically, like the definition of the node is more based on the anatomical space rather than the 2D landmark which was seen in the first talk. And you need to be able to define those space in appropriately to be able to not miss the target. So, for example, we talked about, I'll show some guidelines that for N0 disease 2, 3, 4 is at risk, but for N positive disease you can sometimes treat 1B, 2, 3, 4, and 5, and the base of skull node are at risk for patients with level 2 involvement. And again, retropharyngeal node is a risk for oropharyngeal cancer, but retropharyngeal node is the lateral retropharyngeal node. Then there is a group of nodes called retrostyloid node, which are only at risk if there is retropharyngeal involvement or level 2 involvement. So level 6 again has two parts, 6A and 6B. 6 is anterior jugular and 6B is peritracheal and prelaryngeal nodes. These are usually not at risk in oropharyngeal cancer, but sometimes they could be risk in hypopharyngeal cancer. Again, this is level 6 and this is 6A and 6B. So these are standard nomenclature which you need to follow in your practice. And then I've highlighted some of the landmarks which we talked about it. Now the level 4A has 4B based on whether upper and lower level 4A nodes. In N0 disease, you can probably treat 4A, but if the node goes down to level 3 or level 4, then you have to include 4B. And they use Merriam and 2 centimeter above that as a landmark. These level 4A and 4B are the same node which you contour for breast cancer when you contour supraclav. So they are not anything different. It's just the nomenclature is different. So when you're treating supraclavicular node or lower neck node in breast cancer, they are basically the level 4 node. And this is an example of the retropharyngeal node. So a question came up when to include retropharyngeal node. So the lateral retropharyngeal node is included for oropharyngeal cancer, but the medial retropharyngeal node, which is medial to the lateral retropharyngeal node, is only included for nasopharyngeal cancer if lateral retropharyngeal node is involved or if there is posterior pharyngeal wall tumor. So lateral retropharyngeal node is included for oropharyngeal cancer, but the medial you can skip it, and by avoiding medial retropharyngeal node, medial retropharyngeal, you can decrease the risk of constrictor muscle dose, which can decrease the risk of swallowing dysfunction. And again, the level of retropharyngeal goes from almost up to skull base to the level of hyoid or C3. I mean, normally you don't see that prominent retropharyngeal node, but in this case, to make it visible, it has been identified. This anatomy was already shown. I mean, one landmark I would say that this vertical structure is the base of tongue. So if you're looking at sagittal view and you need to figure out where is the base of tongue, so this is oral tongue, and this vertical structure is the base of tongue. So when you're looking at lateral view, this is the base of tongue, this is epiglottis, and this space is the valvular space. So we're talking about it like it is important that when you are defining the CTVs for primary and CTV for the node, you should be able to identify the structure. And I talked about it for base of tongue tumors are often difficult to define on CT or MRI. So to avoid geographical miss, both CTV1 and CTV2 include larger margins, especially the CTV2. And as I said, sometimes you include the entire ipsilateral base of tongue for early stage and entire base of tongue for advanced stage, rather than trying to have a geographical miss. So if you're not sure about it, rather than giving 10 to 12 millimeter margin, try to be a bit more generous in contouring the CTV2. The CTV1, usually if you have a PET scan and MRI in clinical exam, you can define the GTV with some certainty. As far as node is concerned, there are two ways to define the node. One is any short axis more than a centimeter, or any node which is spherical, has a necrotic center, so it's based both on morphology as well as size that you define the GTV node. So this is a guideline for the base of tongue. So CTV1 includes isotropic margin of 5 millimeter, which goes to the highest dose. CTV2 includes the area of higher risk, which includes entire ipsilateral base of tongue in case of base of tongue primary, or from invasion from the adjacent tonsillar primary. But if there's advanced base of tongue cancer, then it includes the entire base of tongue. For CTV3, which is the tumor confined in tonsillar fossa and tonsillar pillar, as to ipsilateral radiation therapy, which was talked by the previous speaker. So if you have ipsilateral disease in tonsil with minimal involvement of soft palate or base of tongue, then you can avoid the morbidity of treating the contralateral neck because the risk of contralateral failure is low. So for T1, T2, and some T3 disease, and N0, N1, and N2A, you can treat ipsilateral neck. For N2B, it's an area of controversy, and N2C and above, you would not treat it. So by treating ipsilateral tonsil and ipsilateral neck, you can decrease the risk of exposure to the contralateral parotid, which can decrease the risk of xerostomia and mucositis. So tumor of the soft palate, posterior pharyngeal wall, and base of tongue are midline structure. So you always treat both neck nodes. Now the level of neck node you treat could change based on whether it's N0 or N1 disease. I talked about the ipsilateral treatment for the tonsil, limited to patients with tonsillar disease with less than a centimeter or superficial involvement of base of tongue and soft palate. So now for the nodal involvement, like we don't include 1B node for oropharynx cancer because 1B inclusion increases the risk of baseline xerostomia from submandibular gland unless oral cavity is involved or there is bulky level 2 nodes. And level 4B should be included in case of level 4A involvement, which I talked about it. So if there is lower neck node, then you include 4B, which is up to the medium sternum. But if the 4 is negative, you can decrease the dose to the lower neck node. Now level 7B, which we talked about it, is the retrostylar node. You include in case of level 2 involvement. And by decreasing the dose to retrostylar region in patient with N0 disease, you can decrease the risk of xerostomia. So retrostylar node, which is the higher up base of skull node, you include in patients with level 2 involvement. So say somebody has level 2 on one side and N0 on the other side. So on the side of involvement, you will include retrostylar 2, 3, 4, possible 1B because based on the level 2 nodal size or oral cavity involvement, and level 5 node. But on the contralateral side, you can just treat 2, 3, 4. And you'll treat retropharyngeal node on both the sides. So this is these are the guidelines. As you can see, we talked about it for N0 or minimal N1 disease, you include 2, 3, 4 and retropharyngeal node for the posterior pharyngeal wall tumor. For N2A and 2B, you also include level 5 node and retrostylar node. Similarly, for the contralateral neck, you can just get away with 2, 3, 4 node for N0 disease with the retropharyngeal node. But if there is no involvement, if there is involvement of the contralateral node, then it becomes similar to the ipsilateral side. So basic difference between the 2D planning and 3D planning is you can paint your dose. So you can treat more neck on the side of involvement, less neck on the side of involvement. And then the important thing is, we talked about it, like the salivary gland tolerance is like the dose to the salivary gland, we say is 26 gray, but it's not an all or none phenomenon. It's a sigmoidal curve. So 15 gray is better than 26 gray, 26 gray is better than 36 gray. So on the side of involvement, you don't necessarily need to spare the parotid. But on the uninvolved side, you can try to spare the parotid to a lower dose. Now, there is some data which recently got published in nasopharyngeal cancer that you can, even if you spare the superficial parotid on the side of involvement, keeping V26 less than 30%, you can still decrease the risk of xerostomia. So don't get overzealous and try to spare the entire parotid on the side of involvement. You can focus on superficial parotid, but more importantly, focus on the contralateral parotid, because that is more important than sparing the ipsilateral parotid. Now, we saw the hypopharynx anatomy. We talked about it. There are 3 piriform sinus, postcricoid, and the posterior pharyngeal wall are the 3 substructures. And again, the previous speaker showed the area very well on the CT. Now, I would skip the anatomy part of it in the interest of time. But again, the same concept like from the Danish group, which was there for oropharynx is for hypopharynx. So you extend the primary tuber by 5 millimeter for your largest volume. For the CTV2, you can extend by 10 millimeter or so, but sometimes you can include the entire hypopharynx if you want. And in case of T1, T2 vertebra, T1, T2 primary, when the disease is not locally advanced, the prevertebral fascia and the thyroid cartilage are natural barrier. You don't need to include that. But for T3, T4 disease, the prevertebral fascia and as well as thyroid cartilage should be in your volume. The elective node principle is very similar to the oropharyngeal cancer. The only difference is when the disease involves the apex of the piriform sinus, you also include the level 6 or anterojugular nodes. So that's one difference for N0 disease. And rest of it is more or less similar, but only difference, as I mentioned before, for oropharynx, we don't chase level 6 nodes, but for locally advanced hypopharyngeal cancer, or apical involvement of pyriform sinus or post-cricoid region, we also include level 6 node in our volume. So that's one major difference between oropharynx and hypopharynx. The 2, 3, 4A node are at similar risk. And again, 5A and retrostyloid node you include for bulky level 2 or if there is nodal disease. So that principle is same. And we talked about it level 2 we could be omitted if cervical node on the same side. 4 we should be included if 4 is involved. And 7B should be included like the retrostyloid node if level 2 is bulky. And these are so switching gear from the CTV, GTV, CTV, and PTV. Let us switch gear to the organ risk. So I asked the question: what is the tolerance of the spinal cord? And one of the listeners said 45 gray. Spinal cord tolerance is not 45 gray. The tolerance concept came from the old concept that there is a 5% probability of grade 3 complication with the dose. Spinal cord is one organ where we do not reach 5% because you would not accept 5% risk of myelopathy for treating head and neck cancer. So in true sense, the tolerance of the spinal cord is close to 60 gray or above for 5% complication. But we would not accept that risk of complication for spinal cord. So we are very conservative. The 2D approach, which was shown by Dr. Suman, in that era, the spinal cord routinely used to get 50 gray and above because we ignored the contribution for the electron beam. But that was done in the era when chemotherapy was not done. In the chemoradiation era, people are more conservative and they try to limit the dose to 45 gray or so. But in true sense, there is no difference in spinal cord complication anywhere between 40 to 50 gray. The risk of complication is 1 in 1,000, which is not the tolerance dose. The tolerance dose is much higher than that, but we don't reach the tolerance of a spinal cord for obvious reasons. And you can limit the dose to anywhere between 40 to 50 gray. The probability of cord injury is between like 1 in 1,000 to 2 in 1,000. So that's one concept which is different from the tolerance. Now for constrictor muscle, as was shown by in anatomy, like we have superior, middle, and inferior constrictors, starting from pterygoid plate all the way up to the cricoid. For contouring the constrictor muscle, use a 3 millimeter brush, and then you can contour this U-shaped structure as a constrictor muscle. So the U-shaped structure within 3 millimeter brush would be one way to contour the constrictor muscle. We also contour the lip and try to limit the dose to the lip for oropharyngeal cancer. With IMRT, if you don't contour the lip, the treatment algorithm tend to send more beam from the anterior side, and you may see more oral mucositis, which was seen in the previous studies when IMRT started. So you contour anything which you can come in the beam. So not only like the lip, the mandible, the parotid, and the constrictor muscle. For the spinal cord, you can draw the cord and create a PRB by extending 2 to 3 millimeter margin. So the constrictor muscle has become important because like the data has shown that higher dose to constrictor muscle can increase the risk of swallowing dysfunction. So for ease of contour, you can contour superior and middle constrictors, one organ, and inferior constrictors, one organ. And depending on what side you're talking about, you can try to spare the constrictor muscle if you could. And I'll show you some data in that regard. So depending on what site you are treating, you may or may not be able to spare the constrictor muscle. So for oropharyngeal cancer, it's harder to spare superior and middle constrictor. For hypopharyngeal laryngeal cancer, it's harder to spare the inferior constrictor. So you have to optimize your dose according to the site you're treating. Other thing which you have to contour is larynx or glottic and supraglottic and glottic area in the oropharyngeal cancer. There are studies to show that as the mean dose to the glottic goes above 20 gray, the voice quality goes down. I know in some of the literature they talk about 40 gray, but in the modern era with IMRT and VMAT, we try to limit the glottic dose to 20 gray. By doing it, there is some underdosing in the medial neck node, which is acceptable for N0 disease. But as you increase the dose about 20 gray, the risk of voice dysfunction goes up. You also contour the cricopharyngeal inlet and cervical esophagus, and the brachial plexus, especially when you have lower neck node and you're trying to give 66 to 70 gray, it becomes important. And this previous speaker showed up the scalene muscle. So you follow from the root all the way out through the in between the scalene muscle to create the brachial plexus. And you do from like cranial border C5 to T3. So like from C5 to T3, you contour it, and it go behind the anterior muscle, which was shown by the previous speaker. This is the cell. Again, we talked about the parotid gland, both superficial and deep lobe, and submandibular gland, which are easy to identify. So you can go to the anatomical description, but usually both submandibular gland and parotid gland are self-explanatory in terms of how they appear. So this is we are talking about. Like we try to limit to 45 gray, not based on the tolerance, but more based on the idea that we want to limit the cord toxicity to 1 in 1,000, more so in the area of chemoradiation therapy. With VMAT, you have another safety factor because you give 45 gray in 7 weeks, so the dose per fraction is lower. So in essence, you have more safety factor for the cord than we had in 2D era. The brainstem maximal dose to less than 50 gray, but the PRV 52 gray. For the PTV, you want 85 dose, 95% of the PTV to get prescription dose, but sometimes we accept 95 if the organ risk becomes a challenge. So ideally, you want 95% of the PTV to get your prescription dose, which is 70 gray or 50 gray. You want to limit hotspot to less than 110%. You can have a point dose to 110%. Your 1 or 5% vary depending on what technique you use. The brachial plexus point dose less than 66 gray. We talked about salivary gland is 26 gray, but if you are spreading the opposite side more than the ipsilateral side, you can even aim for 15 or 16 gray. Constrictor muscle, I'll show you some example. And for larynx, I talked about mean dose less than 20 gray. So these are, again, when you are defining it, we talked about you draw the lip to limit the dose to less than 20 gray. Submandibular gland less than 39 gray. Cochlea less than 35 gray, and mandible basically no hotspot in the mandible, so try to limit to 70 gray. And thyroid is there is no absolute dose, but you can limit mean dose to 50 gray or below. Now the constrictor muscle has come more so because of this DAR study, which defined two structures: superior middle constrictor, inferior constrictor. And what they did was, this is very important when you're trying to optimize dose to constrictor. The highest dose volume was 65 gray, and they excluded the constrictor muscle from the highest dose volume CTV. So that means if the CTV overlapped the constrictor muscle, they excluded that part of the constrictor muscle in terms of denominator. It's important because if your 65 gray is overlapping the constrictor, you cannot achieve the mean dose which they achieve in this clinical trial. So the part of the CTV which was overlapping the constrictor muscle, the highest dose was decreased. For the lower dose, they accepted underdosing of the CTV, which is again, there is a word of caution. The trial was not designed to look at local regional recurrence difference. The trial was designed to see what's the advantage of dose optimized IMRT for constrictor muscle. Similarly, for inferior constrictor muscle, they tried to limit dose to 20 gray mean dose, excluding from the CTV. So if you look at it, this was what they found, that once they contoured the constrictor muscle, the dose went down from 57 gray to 49 gray, about 15% difference in the dose. And for the inferior constrictor, the dose was almost like 100% difference from 49.8 to 28.4 gray. So because this was mainly oropharynx, it was easy to decrease the dose to inferior constrictor. But what it did was, from patient-reported outcome, there was significant improvement in the MDADI score, as well as swallowing domain. So 25% more dose optimized IMRT patient recovered normal swallowing function by the University of Washington question of quality of life questionnaire. So it's important that, if you do not draw the structure, you would not know the dose. When you draw the structure, you need to make sure you define it appropriately, both superior, middle, and inferior constrictor. Use 3 mm brush in doing it. Exclude from the highest risk CTV, so the denominator is well defined, and try to achieve the dose constraint as defined in the clinical trial. So with this, I want to open up the question, this forum for question answer. I know it was rushed up, but we needed to be done on time. I hope you got something out of it, and let me see how the people answer the question and answer to see if I can go from there. Good. So Eric, we can open up the forum for the question, and in the meantime I can answer that thing. So from GTV to CTV, it varies. Some said 5 to 10 millimeter, but 5 millimeter was for the highest risk and 10 to 12 millimeter for the lower risk. So it's different depending on what you're talking about. If people say CTV to PTV to 3 to 5 millimeter, it all depends on what imaging you're using and how frequently you're doing the imaging. So it's important to be able to define that. Now, some people said 3 millimeter in case of critical structure. I would be very consistent. If you're doing 3D imaging, you can reduce to 3 millimeter. It doesn't matter what structure you're talking about. Sometimes for nasopharyngeal cancer, when the optic nerve or chiasm come close to the picture, people even give 0 to 1 millimeter margin, but that's a very different scenario. I talked about the cord dose. The tolerance is not 45 gray. Tolerance is probably close to 60 gray. But for safety factor, limiting the toxicity to 1 in 1,000 will limit to less than 45 gray. But the tolerance in true sense is 5% risk of myelopathy. For that, it's probably 60 and above. From adaptive planning, it's an area of experimental or area of research, I would say. You don't necessarily change a mucosal CTV, but somebody has 6 centimeter node and it becomes 4 centimeter. So there is regression of the node, anatomy doesn't match. Then you can change your CTV for the node accordingly, but you still cover that anatomical region, but you exclude the part which is out in air and outside the patient. So yes, you can modify the CTV but for the nodal volume, but that is more for the regression of the node, but you still treat that anatomical region. But you do not modify a mucosal margin because that's not what the goal of the adaptive is. If there is lesion both equal outside pyrethrin signs, what should be the primary depth? It all depends on where the epicenter of the disease is. If the disease epicenter is in piriform sinus, bulk of the disease, then you call it hypopharynx. If the bulk of the disease is in the AE fold, then you call it laryngeal cancer. But it becomes semantic because the management principle more or less remains same, whether the patient is a candidate for organ preservation or not. That principle remains the same. Any other question?
No, sir. I think that brings us to the end of the doubts, questions. So any more requests, participants, you can put your questions forward.
Now, I didn't answer the question for conformal radiation therapy, IMRT and VMAT. The dose, like VMAT is preferred just because of ease and convenience of dose delivery. There is no, like the dose distribution looks very similar, although some studies says VMAT has better plan. But that being said, we prefer VMAT just because patient is on the table for shorter period of time. You can be done faster. When you're optimizing on IMRT or VMAT, in the older software, the hotspot used to be 115 to 120%, but the newer software and hardware, your hotspots are usually less than 110%. You still have dose heterogeneity in your CTV, and you try to limit your 105 in the CTV, not in your PTV and organ arrest. But the dose heterogeneity has gone down. In the past, 105 used to be like 70%, 80%. Now with the modern day planning, it's a bit more homogeneous dose efficient. And 105 is more close to 15, 20%. And 110 is close to 0. So things have changed in terms of planning. But when you start these patients on the plan and you have more than a centimeter mismatch with your SSD, then you should reconsider rescanning and replanning the patient to avoid overdose or underdose of the target or the OAR. It's important to be able to see that on your cone beam CT or on your setup on a day-to-day basis. Any other questions?
No, sir, I don't think there are any more requests over you. So thank you, sir, for that engaging session. This brings us to the end of today's class. Anyone has any more questions, you can surely post over here.
Sir, one just last question for you, sir. Sorry.
Go ahead.
Sir, if there is any node which is very close to the skin and in VMAT or IMRT planning, it is difficult to, cover the whole node with the, proper 95% dose in the PTV. So in those cases, do you prefer adding bolus in there, or you will accept whatever the plan is there?
So two things. So I'm glad you brought up the question. So when we do CTV to PTV expansion, if it comes close to the skin, we bring it 3 millimeter from the skin because of ease of planning, because those calculation algorithm at skin are uncertain. But that being said, if skin is at risk, then you may consider small bolus. But say, for example, if your nodal contouring comes close to the skin and you don't think skin is at risk, you should use a module called auto flash, which is there in the treatment planning system. But by auto flash, what you mean is you create a flash in that area. So like 3D, but you do with IMRT or VMAT. You extend your isodose line beyond the skin so that with day-to-day setup and uncertainty, you're not missing the target. Because otherwise what happens, you have a conformal plan, there's no flash. So you may miss the part of the node if you do not have an auto flash built in. So either you can use the bolus if the skin is a risk, but if skin is not a risk, but you are concerned about day-to-day setup and uncertainty, use the auto flash module in the treatment planning system and ask your planner to extend the isodose line into the air in that area, so you don't miss the node with day-to-day setup and uncertainty. Does it answer your question?
Okay, sir. Thank you. Yeah. I mean, sir, is this the auto flash is available in any kind of planning system?
Like it is available in the two major machines. Yes, okay. I've used in both machines. Yeah. Okay. Now the way you use it is a bit different, but the auto flash is a module which is available in both. You commonly use for breast cancer patient when you're trying to do IMRT. You commonly use for the cancer of the vulva when you're trying to create for organ motion and swelling and uncertainty. So those modules are available. You have to define, if you think skin is at risk, you can add the bolus. If you think skin is not a risk, but I want to make sure I'm not missing the node with day-to-day setup, then you can use the auto flash. Either way, you need to extend the isodose line outside the patient's body.
And sir, are you routinely using the adaptive technique in oropharyngeal cancer specifically, or whether the tumor is, shrinked or not, whatever might be the, are you using the,
No, not at this point. The only adaptive we do is like which all of us do in the clinic. You are doing mapping really cone beam CT. If your setup uncertainty or your SSD varies more than 1 centimeter, then you continue the treatment but replan and rescan the patient without interrupting the treatment. So you account for change in anatomy. So like that happens in patients who have weight loss, and that happens in patients with bigger nodes, which regresses. So you have to account for it.
So one last question is there like this, what about the movement of larynx during treatment? What should be done to overcome?
So we tell the patient when the larynx is getting treated, we tell the patient not to swallow during the treatment. And that's why VMAT becomes important. The treatment time is shorter. So you have to instruct the patient not to swallow during the treatment. It becomes very important, especially when you're doing early stage laryngeal cancer. Some people do carotid sparing IMRT for early stage laryngeal cancer. And I have seen patients failing in the anterior commissure and all, because in that situation, you have to use the auto flash module for sure. And also you have to instruct the patient not to swallow during the treatment. Otherwise, what happens with swallowing something, you can miss the target. And especially, like with VMAT, the treatment time is short. With IMRT, the treatment time is long. So most of the time people, when they did dosimetric study, they found that the amount of time larynx was outside the volume was small. But when the treatment time is small, then it can become a significant percentage of it. So ask patient not to swallow, and also use the auto flash module if you're treating early stage laryngeal cancer and the disease involves anterior commissure.
Thank you, sir.
These are very, very good practical questions. And I have seen recurrence because of not understanding that the limitation of the planning algorithm and the organ motion uncertainty. So very, very good question.
So I think that brings us to the end of the session today. Thank you, Sushil sir, for this wonderful session. And any closing remarks?
So I think I did not cover the HPU associated oropharyngeal cancer because that's not seen in Indian setting. So that's the only disease site where we are exploring de-escalation therapy. I've tried to focus on what we see in our Indian setting, where the dose and volumes are what we discussed.
Yes. So thank you so much. So with this, I close today's session today. Thank you everyone for attending.
So thank you very much. And so our the first module, the head neck module, last class will be in the next Wednesday at 7:30 on the larynx and some of the thyroid malignancy. So we'll tune with us and we'll meet on the next Wednesday. Thank you and good night. Good night, sir.
Good night, everyone.